Hello and welcome to our lecture series today on mental health and residency. My name is Zoe Fisher. I'm one of the PGY2s from UT Houston. We have two great panelists with us today. If you want to introduce yourselves, let's start with you, Niall.
So I actually have a little more hair now. It's kind of crazy. But my name is Niall Harris. I'm a second year at Emory University School of Medicine.
And Annie.
Hi, my name is Aniola. I am a second year EM resident at University Hospitals Case Western Reserve in Cleveland, Ohio.
All right, thank you both for joining us today. I'm excited to have a discussion about how we can encourage M4s and medical students to push through and really take their mental health into consideration when joining the EM field. And so what I really want everyone to get out of this presentation today is identifying one symptom of burnout within yourself and how you can better understand when you're stressed, recognizing and naming the specific difficulties in EM that you might come across when it comes to being a person of color and just in EM in general. And then adopting one healthy tool that hopefully we can give you to use during your career to help better your mental health, better your wellness, and have some longevity. And so next, I just want to discuss how people feel like residency is hard. I think in medical school and residency, we're always told it's so hard, I'm so stressed out, but not really understanding what specifically that means. Annie, can you give some examples of what being a person of color and how that can be stressful in residency specifically?
I think there's a lot of ways to answer this question. Number one, in emergency medicine, we see the sick of the sick. We see people that are extremely vulnerable. And so that can be difficult as human beings ourselves. And as a Black provider, there can be mistrust among our patients, nurses, people who don't really know us. We can easily be mislabeled. There have been multiple times where I've walked into a room and had the lunch tray handed to me or just been mislabeled and not as a physician. And definitely having that personal responsibility of taking care of patients that look like me, I have another sense of understanding compared to other providers in terms of their social determinants of health. And sometimes there can be a minority tax of having to explain these things that seem so natural to us to other attendings and nurses. So that also can feel a little bit taxing as well. Just a few examples to give.
Yeah, and I think that's great talking about just the small ways and the people interactions that we might have that really kind of can take a tax on how we're feeling. But also, in general, people of color, and especially Black physicians, have been shown to get harsher standards, harsher treatment compared to their white residents and co-residents. And so I think recognizing that sometimes that old phrase of having to work twice as hard to get to the same place is still present even once you become a doctor. And I think that can be sometimes really overwhelming for a lot of us to finally reach this great plateau of being a doctor and carrying out your medicine dreams and still having those feelings of not being good enough and imposter syndrome that's placed on you by other people. And so moving to the next, when do you know you're stressed? I think now, can you tell us a little bit about times that you knew you were stressed and what that manifested as?
Yeah. I think for me, something I find just really interesting is how, in medicine, we learn so much about how to identify stress and different, negative things going on in our patients' lives. And for our own selves, it can be very difficult to identify that same stress. In my own self, I noticed that just being in emergency medicine, one of the main reasons I did this, I chose this job was so that I could make an impact on my patients, like the vulnerable people, that we take care of. But I noticed that there are times where I may struggle with my empathy, even toward those populations that I care so much about. And in times like that, I definitely will recognize, okay, something's kind of off, I have to kind of readjust and, think to myself, what is actually going on here? And then, working night shifts is something that I personally find stressful, and it can be difficult for me. And I noticed that the stress manifests itself in me just being more emotional, honestly. I think, I noticed one time I was having a conversation with my mom about something related to a patient interaction. And I'm being so like honest right now. I like started crying. I'm like, yo, what's going on? It's something that normally wouldn't impact me, you know what I mean? But I'm talking to her and then I'm like, what's going on? My mom was like, I think you're stressed. I think you're tired. And I was like, yeah, I think you're right. You know what I mean? So once I was able to, recognize that, focus on getting sleep, things of that nature, I was doing a lot better. I was in a much better place, but it just manifests in different ways. And I think people just have to stay attuned to how does stress impact you.
Yeah, I think that's a great example. Getting more emotional, like small things. When your road rage starts picking up for me, and I just like hate waiting at red lights, I'm like getting irritated. That's definitely a time. Sometimes I'll just repeatedly forget things. I forgot my watch at home. I forgot my stethoscope. I forgot my keys, things like that. That's definitely when I notice that I'm reaching a place that's not my baseline, and that my stress is now increasing and it might be affecting my work and just my personal relationships. And so I think that's a great example of how you can kind of check in on yourself, like this isn't my baseline, something's going on. And I think that's a great, yeah, way to just check in on yourself, make sure you're doing okay. And so I think that we talked great about burnout within our personal selves, but I think that goes bigger than that. I think it's definitely a systems-based thing. Here's just the diagram to just show the things that can contribute to burnout. Definitely job satisfaction, dealing with systems, patients, consultants, things that are out of your locus of control, really in an external locus of control, versus things like your internal locus, talking about work-life balance, talking about interpersonal relationships. Can you talk about the way that maybe the consulting system or the hospital system at Case Western works in terms of how that can contribute to burnout and the ways that you felt like disappointed in you not being able to provide the type of medicine you want to, just because of outside system forces, any?
Yeah, so our typical admissions are either to surgery or to internal medicine. And then within that, there's a lot of specialty teams. So it's kind of feel like I'm sometimes chasing my tail in terms of admitting a patient. Do they go to the cardiology service? Do they go to the subset of the heart failure service? Should they go to the electrophysiology service? So I kind of feel like I'm kind of chasing my tail, trying to get the patient to the right place. And then speaking to consultants, they want, some specialized labs and they want other things, some that from an ED standpoint, that workup isn't indicated. So sometimes it can feel a little monotonous, but it's important to remember that, you're doing this for the benefit of the patient. So that can help, overcome that burnout. But I definitely think as an EM provider, you're seeing everyone, you have a high volume. So trying to just kind of stay focused in that aspect and knowing that, other consultants are asking you for these things to help the patient is kind of what helps me get over that tax.
Yeah. Can you talk about now some other ways you've experienced burnout, or like a story that was like a key burnout player for you that you didn't really understand until you got into residency and saw, the type of things you can come up against in this EM career as a person of color too?
Yeah. I think that, being a medical student, so I did my medical school here in Atlanta, Georgia at Emory as well. And so something that was interesting to me was that I saw and took care of predominantly patients of color. And I think that that was something that really helped push me in the direction that I went in, ultimately choosing emergency medicine. But as a medical student, it was something that only invigorated me. It was a source of energy for me, and it still 100% is. But I think that becoming a resident, being so up close to certain things that impact our communities, at times can be, very difficult to witness. It's almost like a secondhand kind of trauma that you can experience. I know that I've taken care of some unfortunate gunshot wound victims, police brutality victims, and in the backdrop of having to, worry about your own safety, having to do that with another patient. I had a particular incident where a patient was shot by a police officer came in and was handcuffed to the gurney, and we had to transport them from the gurney to the bed. But the cop, I can only imagine, was afraid of the fact that they had just, shot someone. And so they never came to the hospital. This is the only person who has the key, and this person has to get rushed to surgery, but we're wasting time. The patient's losing blood because they are locked to the gurney. You know what I mean? And so trying to scramble and find someone who has a key while this patient is like literally dying in front of us. It's one of those things that you're like, wow, I couldn't have really imagined that I would have to kind of navigate not just this experience in real time, but how do I feel after the fact? You know what I mean? The policing force are public servants as well. You know what I mean? We're going to be interacting with them on a regular basis. And so, things like that can just kind of take a toll on you at times in ways that you don't often realize until it happens.
And I think you mentioned a key piece of like, you don't realize it happens in the moment and don't have time to debrief. I feel like in EM, a lot of the times you walk out of those rooms of really devastating things happening, and you have to go straight back into another room where people might be here for something simple or very upset because they've waited a long time, but you just spent 30 minutes trying to save someone else's life. And so sometimes it's hard to do that code switch of like going from something so devastating to still remembering like these people feel like this is the biggest important thing in their life that's happening right now, and still having empathy for, what they're feeling and how long they've waited and things like that. So I think that's a great point to bring up and talk about, that you might not understand as a med student, but once you're in residency, it becomes really a balancing act of how you feel and how you interact with patients. And so just talking about, I think you mentioned being in Atlanta, being at Emory, there's a lot of Black patients and there's a lot of doctors. And I think that's an awesome thing to experience, because we've seen time and time again how having a Black provider does impact the care a Black patient might experience. And so in 2020, they did a study about OB providers, specifically in the Black mortality rate of infants, and showing that it improves when they do have a Black provider. Same thing with this 2018 article, having a Black cardiologist improving the mortality and morbidity of Black African Americans going with their cardiovascular disease. And so just discussing how has having any Black faculty or any other Black residents impacted or improved your experience in medical school, and how can it make a difference?
I just think from an advocacy standpoint, you don't feel that you're the only provider advocating for your patients in terms of, I always ask my patients, how did you get here? Because not everyone drove. Some people took 8 buses to get to where we are. Always asking them what medications they're on, because legitimately in Cleveland, some people don't know how to read. And when you have attendings of color that understand those social determinants inherently, it's kind of easier to keep things moving. You provide better care to your patients because you don't make assumptions about their knowledge. You kind of meet people where they're at, and you have another threshold of admitting someone versus discharging them, because a lot of these patients don't have primary care follow-up. They can't see people in the more outpatient setting. So kind of meeting people where they're at it's very relieving to have attendings of color when I'm on shift.
Yeah, I can remember a story too, where we have our trauma ED that we run through, and I was handed off a patient who like already got stitches, just needed to like finish up some labs, then could leave. And then when I was about to discharge her, she had like her wig on, and I just saw the staples go just to the point of the wig. And so I removed it, and there's like a huge cut going all the way back. And I think that's just something like that we would feel comfortable, like, girl, we need to pull this back a little bit so I can see what's going on under there. But that other providers might not have considered, might not have thought of like, oh, this is your hair, I just can't see, beneath it. And so that type of cultural competency of like knowing you got to do a little bit more investigation, it's something small, but it's something that I think as Black people and people of color might have more experience with, to know to look a little further and to do an extra step that some people might not even have considered. And I think that can benefit patients in a lot of different ways that we're not even realizing the full potential of. And so I think you even touched on this earlier, Niall, about violence EM, and that's something I really wanted to discuss overall. We see a lot of violence, not just against us as healthcare workers, but just interpersonal violence, non-accidental trauma, police violence, gun violence, especially in some of the cities that we live in. Niall, can you give any more stories or ways that you've interacted with, one of these bubbles that has really impacted you and changed the way that you think and move?
Yeah. I think that something that's interesting to me about, witnessing violence as an EM physician, like working in trauma centers, I realized that I've kind of downplayed the ways in which I myself may have experienced violence while being in the emergency department. I think that there are occasions where, patients might have mental health issues going on and they might be having a psychiatric episode. And so, I remember the first time I saw a patient that had to be, physically restrained and chemically sedated. You know what I mean? Like, that's not something that you see often ever, unless you're in the hospital or the emergency department or maybe in like a psychiatric emergency space. And so just seeing that sometimes can really just, it doesn't sit well with you all the time, or really ever. And it's something that you kind of have to choose to be aware and present for, because I think what oftentimes happens as physicians, when we see these different things that we see so commonly, I think it's very easy to, have a negative experience going on, a traumatic experience for you and the patient, and you kind of just brush it off like it's not a big deal. I think something that I try to practice is, if I'm having a crazy trauma come in or something that I know is devastating to me as an individual, I try to really embrace that moment, honestly, because I've had experiences where I ignore the feelings that might come up after the fact, and they really can just compound on themselves, and then they might make me less easy to interact with in the future in my more interpersonal relationships. And so I think that we do see quite a bit of violence in Atlanta. Unfortunately, I see quite a bit of violence as it relates to people who look like us, and it just sucks. But you have to find folks you can talk to, whether it's a therapist, a friend, a family member, and try to debrief, or even your co-resident, just try to debrief on these things. I don't think it happens enough, but it has been the most valuable thing, I think, to me as it relates to this issue.
Yeah. And as a Black woman in Cleveland and having a lot of gun violence there, how do you handle that when you have a lot of gunshot victims? What does it feel like to go through that experience?
I think it's important to acknowledge that the stuff that we see and do is not normal. Like, it's not normal to see people die every day. It's not normal. The procedures that we do are crazy. That it's not normal. And it's kind of easy to become numb to that. And we kind of feel like something's wrong with us if we cry with a patient or if we're sad about something. And I think it's always important to remember that we're human too. We have a very, very strong police presence in our emergency department. We have Cleveland PD. We don't have regular security. We have Cleveland PD in our emergency department. We have a very strong Blue Lives Matter support system in our emergency department, but a majority of our patients are Black. So kind of understanding their triggers and knowing that someone that might be threatening to a nurse or a medic who is not Black, their threshold is definitely lower compared to me feeling unsafe. So kind of as a physician, making sure that your staff feels safe while at the same time advocating for your patient, because when a psych patient comes in, think about the things that we do. We take their clothes away, we take their phone away, we lock them in a room, we put them in scrubs that don't feel good, and we have them sit there for hours. Maybe sometimes they're boarding in the ED for 2 days until they can get a bed at a psych facility. And so kind of that's going to bring frustration, number one. And then when, there's some people who call the police on these patients, that can be a trigger for them based on their childhood, based on their previous history with the police. So there's a lot of things to juggle. And knowing that you're the physician and you're there to advocate for your patient while also making sure that staff feels safe, it can be difficult, but it's definitely a skill that you will obtain as you move through residency, and definitely reaching out to your attendings and expressing your vulnerabilities and saying, I'm not comfortable with the police based on my history. Can you help me with a debrief, or can you kind of talk a nurse down? Definitely delegating responsibilities and asking for help is really important in trying to maintain your safety and your sanity.
Yeah, and I think talking about your specific triggers is really important to mention, because I definitely am very sensitive to like any type of domestic abuse, especially when women come in like beaten from their boyfriends or their husbands. And so I think that carries like an emotional burden longer for me than some of the other like bread and butter things that we see in EM. And I think recognizing like, ooh, I'm really sensitive to this, like things that are being done for this patient quickly, I'm more upset, I'm more anxious about. I definitely carry that trauma home. And so talking to the other residents that I have on, talking to other people of color, and just mentioning like, I know this is very sensitive for me. And whenever I have these patients, I really get protective over them and make sure they're getting the best care and getting the best treatment possible, because they just went through something major. And so I remember specifically a patient that wanted to leave, didn't get seen, is just in like the panic post-trauma state, is like not thinking clearly, needs stitches, needs everything else, and is like leaving AMA. And I'm just sitting there spending like 30 minutes trying to talk her down. And it didn't work. And that really devastated me. She still left. And I gave her like precautions of like, please come back anytime, at any point. You don't have to, just because you left doesn't mean you can't come back, type of thing. And so that person, I still think about her to this day, like whether she's okay or not, where she went for safety, whether she went home or not. And I think that's the type of thing I didn't realize was going to happen often until I got into residency and really started having these experiences. And I think that's something that I definitely want to share with the people in med school right now, to kind of figure out what is your trigger, what is situations that you feel that are going to affect you emotionally, and how you can go about really debriefing and protecting yourself and talking it out with other people, so you don't carry that continuously and it starts to erode how you feel about medicine or how you feel about being a doctor in general. And so I think that's, as a Black woman, seeing those Black patients leave and things like that, it really tears at me and really sticks with me. I kind of had to navigate how to better address that with like therapy and other things like that. So thanks for sharing. I want to go on to talking about coping tools. Can you think of a time that you had to cope with a traumatic death or something, patient that you had that really impacted you, and what you did to kind of work through that process?
Yeah, I think just, we see a lot of death in the emergency department. We see a lot of very unfortunate trauma. We, tell people that they have cancer and they didn't know it. And I think it's important to stay strong for your patient. But I think, sitting down next to them and gauging the room, and sometimes it's okay to have an emotional response with the patient. Just remembering that even though you're a physician and you have to be hard and you have to be, strong, it's also okay to be vulnerable. And I think patients definitely appreciate that. And I think that also will help you in the long run to just remember, I have a pulse too, and I'm human too. And it's okay to, tell your attending, I need to take 5, I need to take a lap, I need to call somebody, I need to just take a break from the things that we see, is really important. In addition to therapy, I go to therapy every Thursday. I recommend it. It is so important. It definitely helps. Go to therapy.
Love that. And I think you said exactly what I would recommend is like recognizing that there's something off. We talked about ways to identify your stress, kind of investigating, why do I feel this way? Is it because I've had some painful deaths recently? Is it because my personal life might be going through some things? Is it because I'm just sleepy and tired, like Miles said, and he doesn't want to work nights anymore? And so kind of figuring out what that is and addressing whatever it is. Hey, I need to talk this out. Hey, I need to take this day off, I can't go out tonight, or hey, I need to maybe just do something fun and kind of get my mind off of medicine. I think finding some tools for coping and figuring out what exactly that is really what's going to contribute to improving your life overall, improving your wellness overall. Now, can you think of some patients that you might have had that you realize, oh, I kind of got to figure out how I'm going to address this, how I'm going to investigate why I feel so badly, or something maybe later on that you realize this patient's really sticking with you and you didn't realize it, and how you kind of went about healing from that process?
Yeah, definitely. And first, shout out to therapy. Therapy's
Shout out
great.
to therapy.
No, so I actually just finished a rotation in the surgical ICU back in December, and it was a rough month. And I think that, yeah, I definitely had a patient interaction that sticks out to me the most. I had a 16-year-old who um, unintentionally shot himself, resulted in him being brain dead. And so, you know, as you guys might know, like brain death is a process. That's not something that you can, you know, you can't see someone and say, oh, they're brain dead. Like that takes days and days and days and tests and CT scans and things like that. And so it was a really interesting experience because this was a young man who obviously was taken away in a way that it shouldn't have happened. He was too young. It was unintentional. He was Black. And so his family members were looking to me as someone who was like their liaison. Like they saw me in the room. They're like, okay, yeah, we're gonna get some good care here. And something that was really distressing for me was like, I was building great rapport with the family. And I felt like we had a great relationship. But what I think was eating me up inside was the fact that every time we were to communicate with one another, I was sharing bad news. I only had something negative to say because of the devastating injury. And it just really hurt me personally to feel like this family was, happy to see me. They were so proud of me, but I could only relay negative news to them. And so the way in which I coped with that personally, like we talked about, therapy was one, but I took it upon myself to, days after the fact, I know the emergency room is a place where we see patients, in an acute setting. But I took it upon myself to reach out to the family and just do a check-in, say, hey, this is Dr. Harris. I know that we had a patient or an interaction in the past. I just wanted to check in and make sure you all as a family were doing okay. I'm so sorry about XYZ that happened. And that's just so simple. You know what I mean? Like it was completely professional. Nothing was out of the ordinary, but it was just me extending my care beyond the patient to their family. And I think that was something that really helped me to navigate that experience and sleep at night. You know what I mean? So just little things like that, I think, can make a difference.
I think that's a great example of like going beyond and having this care for these patients, but being able to close the loop. Because in EM, sometimes you're not able to close the loop. They go up to surgery, they go, out to the outpatient, and you're not sure if they ever followed up and they're not sure what happened. But if it's still weighing on you, there is a way to just check in and make sure, they were able to follow up or they didn't understand anything, and kind of taking that patient onus. I think as Black physicians, we have a closer relationship to some of our Black patients. And so taking that extra step, I think is beneficial for them and us in a lot of ways. So I think that's a great example. And then I just kind of want to cycle back is residents and people residents experience in the microaggressions that we sometimes experience, and how we can best address those systems, because I think it's bigger than just the one-off, one bad apple, one bad attending thing. It's kind of ingrained in healthcare now. And so what are some ways that you have gone with either reporting discrimination, reporting or addressing any type of microaggressions that you might experience as a woman, as a Black woman, as a Black man? I'm sure you've been mislabeled many times. And so kind of how you go about addressing things that might happen in the hospital. Any, do you want to start us off of like something that you might have needed to report, or how you went about calculating what to report and how to kind of go about those situations?
Oh, do you have time for this? Because I got a list.
I have time, plenty of time.
I just think it's important to note that if it makes you feel uncomfortable, you should go with your gut, and that if something just doesn't feel right, then it's probably not okay. If you're not comfortable speaking up, there's a lot of other avenues I'm sure that all residency programs have in terms of talking to your attending on shift. If you don't want face-to-face contact, writing it down, sending an email later. Um, I personally am a more direct communicator, so I'll ask the person, what did you mean by that? Or, tell someone if something was inappropriate. But there's a lot of different ways that you can report that can be direct or indirect, but definitely go with your gut. And if something just doesn't feel right, then try to figure out why that was. And then if you should report it, then you always should report it, because these people will do it again and again and again and again and again. And I think it's important to hold people accountable, especially when you're in a teaching hospital.
Yeah, I think what you mentioned, like asking clarifying questions, that kind of leads into like the action type of statement of how to address microaggressions or interpersonal aggression. So asking clarifying questions is the A. Come from curiosity. Like, what did you really mean? Like, did you really just mean that to be a joke? Where are you coming from when you're saying something like that? Telling what you're witnessing factually, like, I saw you not really care about this patient's pain, and that really hurt my feelings. And then exploring the impact that that made is the I. And so this could really affect them. This could really affect me, and the ways that that might impact you physically, mentally, otherwise. And then I think this is probably the hardest one a lot of us do, is owning our thoughts and not kind of backing down. Like, I know you didn't mean that, and it's okay that you did that, but no, like actually saying that hurt me. This is not okay. This is unprofessional. And like letting that be the final sentence, and not kind of giving people a way out of not really owning what they did wrong. And then next steps. So like in the future, I'd appreciate it if you did it this way, or in the future, I think you should consider this before you make a statement. And so that's kind of just a way to address some tools to address interpersonal conflicts or one-on-one microaggressions or discriminations you might experience. And I think it gets a little easier, to be honest, the higher you get in medicine. I think a med student talking to an attending like that is a lot different than you talking to your co-residents like that. And so I feel like my confidence has definitely grown in addressing things and being like, no, I'm actually in charge of this patient's care. I'm actually an adult and a doctor, and like me being treated a certain way is not appropriate anymore. And I'm not going to necessarily take it in the way that I would if I was an undergrad student or a medical student. And so I think that's one of at least the benefit I've seen in residency, and a growth that I've seen in myself in residency, is being more adamant about not taking anything. So the people coming up behind me also don't have to take the same things that I took. Now, do you have experiences where you had to kind of address some discrimination or address someone's conduct that you felt like was inappropriate for people of color or for yourself or anything like that as a Black man?
Yeah, definitely. I feel similar to Any, in that I try to address things in the moment. Of course, I'm not about to like blow the spot up or anything, but I'm definitely gonna, we're gonna talk about this. I felt like that was problematic. And I think that you definitely can build the reputation, not as someone who is like a tyrant, but people garner this respect of, okay, maybe I should address things more appropriately, or try to be more cognizant of how I'm communicating or addressing certain issues when I'm around this person. And I think it goes a long way for our patients. I've definitely had experiences where, I'm walking around the hospital with an afro. A lot of times I got braids in, what I'm saying, I got a nose ring. Like, there are things people will say that I will have to speak on. And I've had moments with consultants where, they are treating patients in a way that I deemed as inappropriate, based on, just certain lack of care towards certain social determinants of health and different things like that. And I've had to speak with people like our program director to where things have gotten escalated in certain ways and ultimately addressed. But I think that a lot of times too, we come from a culture of, don't snitch, don't say nothing, you know what I mean? But I think it's more important to just realize you're really trying to correct certain systemic issues that have been left to just flourish for years. You know what I mean? That's why we are even having this lecture, is because certain things have been able to fester for so long. And I think it can be a tax, but we have to, kind of nip things in the butt as we see them.
Yeah, I think that's good. Yeah. I think that's really, we're doing this bigger than now was offended by something said. I think we're really trying to address, like, I don't want this pervasive idea to continue to go for more patients and more Black residents and more other people of color that might be coming into the hospital. And so when getting nervous about like addressing things, that's kind of what I look back to, is that it's not just about me and how I feel in this moment. I'm really trying to stop an idea that might lead to more abuse, more discrimination, more harm towards me or towards other patients. And I think looking at it from that lens, it's a little easier to go through, because I think a lot of the times we feel like, oh, you're just being too emotional, or like you're being sensitive, or whatever they like to use to gaslight people, for standing up for themselves. And so I think that's a great way to kind of go forward and kind of think about, why are you doing this? It's bigger than you, and the ways that you can do it firmly and professionally, but not being a tyrant, like you said, and being that person that, kind of takes things off balance. And I think that was a great way to put it. And so just looking towards, the end of our slides and kind of wrapping up everything we've talked about today, I hope you're able to find out some burnout symptoms within yourselves, whether that be how you're feeling, how emotional you might be, the ways you forget things like me. And so figuring out what that is, I think we've talked definitely about the things that we might come up during residency, especially AAEM as a person of color, experiences you might have that you can prepare for now, that you can think about now, figuring out your triggers and how to best adapt around them, and figuring out how you're going to stand up for yourself, for your patients once you get into this field, I think is the exciting part. I think the passion that you feel during medical school, please let that translate into how you become a resident and a future doctor, because that can only propel you forward. And so I want to thank our panelists once again, Eniola and Niall, for coming and sharing lots of wisdom with everyone here. I just want to share some of the additional resources we use for this presentation that you all can look up in terms of discussing burnout rates, and discussing how Black doctors impact Black patients, and then ways to combat tools of burnout and tools of aggression and discrimination that we might come up against. And so thank you so much to AAEM for sponsoring this lecture. We hope you were able to take some things away that you can use in your career. And so thank you again all for coming. I hope you enjoy your day, and I hope you learned something from this lecture. Thank you so much.
Thanks for having us.